So we have a great case for you today. We'll demonstrate many things. This is a multivessel PCI case in a radiation-induced CAD. So we have a 51-year-old male patient with a history of thoracic radiotherapy for Hodgkin's lymphoma at age 16. No past medical cardiac history. He's admitted at a peripheral hospital with a non-STEMI where the angiogram was done. His labs were normal except for a troponin that was positive. Next slide, please. So here you'll see the coronary angiogram of the left system, and it's very characteristic of radiation-induced CAD, where you have mostly proximal disease. So if you look at the left main, it's diffusely infiltrated, but mild disease. There's a proximal circumflex significantly diseased, and the LAD, it's tortuous and multiple levels of stenosis. Next slide, please. Image of the RCA showing diffuse proximal disease with subtotal mid lesion with heavy calcification that you can appreciate before the injection. So the patient went along to have an echocardiogram that showed a normal EF with mild aortic stenosis, and the patient was referred for surgical consultation that was turned down due to the history of thoracic radiotherapy. So the patient was referred to us for multivessel PCI, and I think there are many things to discuss at this point regarding the management of radiation-induced CAD and how these patients evolve surgery-wise versus PCI-wise. So I'll let my colleague go through the objectives of the presentation.
So the objectives are to identify imaging findings of radiation-induced CAD, as well as to identify therapeutic option for calcified plaque modification, and as well identify left main management based on imaging findings and approach to distal left main bifurcation. So the plan for today is an imaging guided orbital atherectomy of the RCA, which we just have finished just now, and then to do an imaging guided LAD PCI and distal bifurcation management accordingly of the imagings, and as well to do the angioplasty of the circumflex more or less with atherectomy or intraluminal lithotripsy.
So we've had quite a bit of time to start off the RCA, and it's a very interesting angioplasty that I'd like to go over. We did it just before coming online. So can I have the first image, please, of the angio? So our setup is a right radial slender sheath 7 French. I took the 7 French mainly for the left system. And the plan of today, as Quentin went over, was to perform atherectomy of the RCA, followed by imaging to understand better the radiation-induced CAD that we have here and the extent of the calcification, because depending on what you see on imaging and IVUS, it will determine significantly how you need to modify plaque and what kind of therapies you need to use. So upon cannulation of the RCA, there was significant ventricularization. And as you can see before the injection of the dye, we can see a lot of calcium. But I think it doesn't give you a fair idea of what's going on in the vessel. So we crossed the distal lumen with a workhorse wire that we then swapped for the Viper wire. My choice for orbital atherectomy here was mainly because I thought that with this kind of CAD, we are very likely to be dealing with deep calcium. And in the context of deep calcium, you need a therapy type that will affect the deeper tissue. And if you take rotational atherectomy, for example, you will just affect the superficial tissue, the superficial calcium, and then you might not get good expansion following that. And as you'll see in the coming case. So next image. Next, I would have liked evidently to do imaging before atherectomy, But since the lesion was subtotal, I decided to go on atherectomy first. Can I see the atherectomy, please? So as you know, the orbital atherectomy, it's a 125 burr, 1.25 millimeters burr, and the sanding occurs antigradely and retrogradely, and the burr is mounted eccentrically. So you get more touch of that deep calcium. So it went easily through. I had some resistance in that mid lesion of the RCA, but still there was no resistance. And I had a few episodes of bradycardia. So usually when you're doing atherectomy, if you do not have a pacemaker in place, you should limit yourself to 10 seconds of atherectomy and use vasodilators when needed. So following the atherectomy, we exchanged the wire for the workhorse wire, not to cause distal dissections. Next. We took an image post-atherectomy. We had some spasm in the PDA that would come back later on. Next. Then I performed pre-dilatation. We performed IVUS. So let's see the IVUS first before the pre-dilatation. So the first image of the IVUS. So imaging is extremely important in cases like this because it gives you a good idea of the distal vessel. We measured 3O as a distal landing zone. Can you play the first IVUS, please? We want to play it fully. So as you can see in the IVUS images, there's some calcium there. There's tissue hyperplasia, but as you see, the more we get proximal, the thicker the calcium becomes, the deeper it becomes, and the more concentric it will become. So now we're getting into the mid vessel. You see there's a calcium arc that's starting, and now the calcium arc is completing. And now it's a 360 calcium arc with deep calcium. And the more we get proximal, the more the calcium thickens. Now we have a complete 360 arc with deep calcium. And this type of calcium, if you decide to tackle it on with only balloon and no calcium modification, you will not have good results. So after the first IVUS, we performed pre-dilatation. So let's see the pre-dilatation balloons. Let's see the first one. So as you can see here, there's possibly a waist on that balloon. Next image. Next image. So observe closely the ostium of the RCA. There's a clear waist, and this is where we saw on the IVUS, very deep calcium and very thick concentric. So this is a 3O balloon that we went up to 18 atmospheres, and we did not get expansion. So probably an error here would be to try to deploy the stent or even try to go higher on non-compliant balloons because they could rupture, they could cause aortic dissection at the ostium of the RCA, and they could get entrapped even if they rupture distally. So at this point, I had used orbital atherectomy already, which is known to get to the deep calcium. And following that, we decided to take lithotripsy. So we took a shockwave balloon, 3.5. We performed one cycle at the mid segment. Can we see the shockwave expanding? So this is a 12 by 15, a 3.5 by 12 by 15 balloon. Then we went proximally. As you can see, the waist is expanding gradually. I performed at least 4 cycles in the ostium. Next. There's still a waist. Next. And now you can see full expansion of the shockwave balloon, 3.5. I went up to 10 atmospheres with the shockwave. So after the shockwave, I went to imaging because I wanted to make sure that my calcium is fractured, because only then that you can deploy a stent and have good results afterwards. So let's see the second IVUS run. So you'll see the more we get to the mid segment, then we'll start seeing the fracture in the calcium. And it's very impressive if you compare both IVUS images, and it shows you that you really need to tailor your therapy according to what you find on imaging. So as you can see the fracture now, you can see them clearly at 12 o'clock and 6 o'clock. And all along the proximal segment, it's all fractured. And as we get to the ostium, you'll see that thick calcium with 2 segments of fracture. There you go. Excellent. So let's take a look now. I took the same 3O balloon, a new 3O balloon, non-compliant to 20 atmospheres. And you can see that there's no longer any waste. Next. Perfect. So at this point, it's safe to stent. You'll know you'll have good expansion. I took a first 3O 38 stent that I deployed distally. Post-dilated with the stent balloon to 20 atmospheres. Then I took a final stent. Can you go back one image, please? If you notice, I have a wire in the aorta. It was not clear to me exactly where the ostium is. So I usually use this trick to identify the ostium. So I put the wire in the aorta, which limits my guiding from going in, and it gives me an idea of where to place my stent. Then I took a 3.5/28 stent, deployed it in the lateral view to be sure that I nailed that ostium. Next. We went up to 18 atmospheres. Next. And then I took an uncompliant 3.5 just to touch up the whole vessel. Next. Then I performed IVUS one last time. Let's see the IVUS images. So as you can see, I have very good expansion on the stent. Tu peux accélérer pour voir la partie proximale. Now we'll get to the proximal segment. And as you can see, it's round. There's no D-shaped. And the stent is well expanded, well opposed. And I'll show you now the final images of the right that we finished just before going online. Next. I think it's a very good result, in my opinion. Great. So now the plan is to move on to the left system. And before performing angioplasty of the left system, I wanted to evaluate by IVUS to determine the idea. So for the left system, we have a 7 French XB3O. I took a 3O because the left main was infiltrated and I did not want to cause any issues. Prenez une grande expiration, monsieur. Respirez, monsieur. So putting the XB in the left sinus. Test. We have good pressure. Well, we're cannulated in the left main. So maybe we'll take a couple of setup shots. On va aller en 15-25. On va prendre le guide de run-through. So we see much less calcium on the left system than we saw on the right system, but still. So the circumflex looks pretty calcified to me, and there's clearly distal main disease. Okay, on va aller en 10-40. For sure, the issue with atherectomy in this kind of case is that you need only one wire. And there's also the tortuosity in the LAD. So we'll bring down a workhorse and we'll perform imaging to see what's going on exactly. in the LAD left main, get the MLA of the distal left main. On va aller en 15-25. Mettre le torqueur. And then depending on the amount of calcium I see in the LAD, then we'll probably perform orbital atherectomy in the LAD and probably use shockwave for the circumflex to maintain my wire axis. Count. What's this? What's the last ACT?
302.
302. 302. Test. I don't have enough curve on my wire, so I'll take a second wire and put it down in the LAD. Can I have a second wire, please? Yeah. So for sure, in terms of complexity of handling the distal main with atherectomy and the calcified circumflex, it will be a challenge. But I'm very curious to see the IVUS images. I think it's a safer technique to just use a second wire. Test. There you go. Test. Now we have a loop and that's safe. Okay, so let's perform IVUS and see what we're dealing with. Prendre impression au brassard, s'il vous plaît. We had some instability during the RCA atherectomy.
Faire le 0.
There certainly could be a challenge crossing, but we don't have any subtotal lesions. So I'm confident that it should be okay, at least to get some images prior that will give a good idea of what's going on precisely in the left main. There you go, IVUS is through, which is a very good thing. And we'll get proper sizing of the distal main. Okay, so let's start the IVUS pull. So there's no disease, as you can see in the mid LAD. Now we're starting the pullback. That's the tortuous segment where we see severe disease. There's no calcification at this point. But the more we get proximal, the more we see of a calcium arc. There you go, calcium arc. 360 calcium arc with deep calcium at 12 o'clock. We're getting to the left main bifurcation. Proximal LAD is all affected. Now is the circumflex coming in, and that's the distal left main. Hyperplasia, infiltration. There's less calcium in the left main compared to the proximal LAD. They go off. So if we look at the IVUS to decide on the strategy, the options are either to perform a atherectomy of the LAD, followed by wiring the circumflex, and then shockwave of the circumflex, versus just shockwave everywhere, which will maintain wire position. Can I have a measurement of the LAD at the start of the LAD, please, a diameter? Okay, measure there. Diameter, yes, top to bottom. We have a 4.0 LAD. Can I have a measurement of the left main, please? The proximal left main. Go further. Go down, go down, go down. More, more, more. Yeah. Let's get the beginning. No, no, no. Go further down. Proximal left main.
Tout en bas. Encore.
Further, further. Go beyond.
Yeah.
There. And let's measure there. Go further beyond. Okay. Parfait. No, I need you to measure the external elastic lamina. Go beyond, down, wall. Further down. Yeah, I need that measurement. So we have a left main of 4 external elastic lamina. Go further beyond. So we'll perform orbital atherectomy of the LAD. Let's take the microcatheter and let's take a 2.5 balloon for trapping. Mm-hmm. Do you have any 2.5 balloon, old 2.5 balloon? So safest way, in my opinion, is to deliver a workhorse distally and have a microcatheter. And since we did the IVUS first, the microcatheter wasn't uploaded. So now we'll perform trapping of the wire to be able to bring up the microcatheter safely. So trapping in a 7 French, you ideally need a 2.5 balloon, minimum. You bring it up to the distal tip of the guiding and you inflate. So I think reviewing the images, I'm going to perform orbital atherectomy of the LAD left main. Followed by this, I will wire the circumflex and perform shockwave if needed in the circumflex. On, go to 12. So trapping, my balloon is on in the guiding. You'll see I have no pressure, which is normal. Then I bring up my microcatheter over the wire, which is very safe. And then once the microcatheter hits the balloon, that's where in the tip of the guiding, you'll get the wire. Then you can go off the balloon. There you go. You can hold the wire, please. Fixed point. And then we'll take the trapping balloon out. And then we'll deliver the microcatheter distally. And then I'll bring in the Viper wire. Okay. Viper wire. So the Viper wire, for those of you who are not used to doing orbital atherectomy, is a body of 0.012. Ça, c'est l'autre bout. And the tip is 0.014. Versus the rotational atherectomy, which is a 0.009. And it's an exchange length wire. So let's deliver the wire distally. We'll take out the microcatheter. Okay, viens, Quentin. So the orbital atherectomy has 2 speeds versus the rotational. It has a 80,000 or 120,000 revolutions. Floro? Attention au sang. OK, on va préparer l'orbital. Watch the wire. OK.
Bon.
Good. It's recommended to loop your wire so you have full control. I prefer to use the one-man technique when doing my atherectomies. That way I have full control. Let's start the flush, on flush. As you can see, the diamond burr, where you can perform antigrade and retrograde sanding. And if you look carefully, it's eccentrically mounted. There are people that perform rotational atherectomy with a wire in the side branch protected with a microcatheter, but since here we don't have subtotal disease of the circumflex, I prefer not to do that, not to lose material. So here's the device. To test it, you lock and then you test. Like button, this is how it works, off. So it's good to go. Then we'll go and get the flashing button on. We'll go on glide assist. And the one-man technique is like I show you. I pull with one hand and I advance with the other hand. Can you please take the wire? Be careful of the wire. Until you reach the tip of the guiding. And then you perform atherectomy. So I'm at the tip of the guiding now. I will stop the glide assist, put it back on. Then you lock the wire to perform the atherectomy. Make sure that everything is straight, turn it on, and here we go. So the machine usually beeps after 20 seconds. So the technique is very different than using rotational atherectomy, where you need to do slow advancement. If you have resistance, you slow advancement to give it time to work the lesion. Here we have some resistance, extrasystoles. When you hear the beep, that's when you should stop. There you go. When you stop, you let it breathe. Make sure you don't get no reflow. And then after 10 seconds or so, you can restart again. I want to make sure to get that bend, to have good expansion afterwards. Here we go. I want to stay away from that second curve because I don't want to go there. Because as you can see, there's a bend while contraction. I do not want to have any stent fracture. So I think this should do the job. We'll do a small test, make sure that things are good. Things look pretty good. And out we go. So to go out, open the lever. All right. So I hope the RCA was educational enough. And I still have a lot of work to do. Continue. So we'll go on glide assist to remove the burr, open up, fluoro. Make sure you have a good look on that wire, not to lose position. Then out you go. After this, I will wire the circumflex, start ballooning. And probably my left main strategy here will be a mini crush or a tap, depending on the angle that I see after pre-dilatation. C'est bon?
Yes.